this is going to be like the first half hour after birth, right? So they're going to be alert, they're going to be crying, looking around. They may have a little bit of tachypnea or tachycardia that happens. During that time period, you may hear audible grunting, you may see some nasal flaring going on. But again, they should start to decrease then and return back to their normal ranges. Then they have, I always say this, then they go to sleep, right? They have this period of inactivity, right? So a couple hours after that period of reactivity, then they have inactivity. So they start to go the opposite. Instead of being tacky, they start to become Brady, right? And they're kind of real sleepy, they're not interested in eating. And then they get their second wind and they come back, right? So alert and active and they want to eat again. So they kind of have this little flow as they're first born. We want to look at their respiratory function, right? So they can have what's called transient tachypnea of newborn. Again, watching the baby, if they have it too long, again, they may need to spend some time in the NICU until they get that under control. They're obligate nose breathers, right? So we always have to make sure that their airway is clear. Again, remember we're going to suction first what?
Mouth.
And then nose. All right, respiratory rate should be 40 to 60. Again, if they're less than 30 or more than 60, we want to get them evaluated. Sometimes they can have apneic episodes. That could be from things like hypothermia, hypoglycemia, or even sepsis. So again, recognizing that. Looking at signs of respiratory distress like nasal flaring, retractions, grunting, all would be things we'd want to work up the baby for. Cardiovascular wise, excuse me, so you can see in this picture an example of acrocyanosis. They kind of have those like bluish purple feet, right? So that's normal in the first 24 hours. Their cardiac system's readjusting. We expect their heart rate to be 110 to 160. You want to take an apical pulse on all infants. You can check, obviously, brachial and femoral pulses, but again, the more accurate way to assess their pulses via the apical pulse. Their blood pressure, systolically, should be 60 to 80, diastolically 40 to 50, with their MAP equal to their gestational age. So if they're 40 weeks gestation, their MAP would be 40. We look at their pallor, we look at their pulses, as well as their capillary flow. We look at their blood, their hemoglobin, their hematocrit, their red blood cells, their platelets. Yesterday we had a baby. They were worried. Mom, I guess, had issues with low platelets, and so they were assessing the baby. And they sent, 2 samples? They kept clotting up. They're like, I guess it's okay if the blood keeps clotting, right? So, looking at that. We also want to have them, as they adjust to the outside temperatures, right? So those babies have to go through thermogenesis, right? So they may increase their heat by increasing their activity to increase their heat. Sometimes that increases their metabolic rate, right? So we want to make sure that they have enough brown fat on them to support that. They can get cold stress. So again, temperature below 36.5 Celsius can lead to cold stress. We talked about that during our sim day, with that kind of lethargic, they could be tachypnic, hypotonic, and not good for nerves. We want to make sure that the baby's voiding. The first few hours after life, they may not have a void, but again, as they start to take in more fluid, they're going to have voids. They're going to have their first stool, that meconium, kind of black, tarry, stretchy stool. Their normal colonic bacteria establishes about a week after they're born. And then sometimes they can develop, especially if they're formula fed, allergies. So we start off with the regular Similac or Enfamil or Gerber, whatever brand they go by. Sometimes, again, if they go by WIC recommends a certain brand, like it used to be Gerber, I don't know if the stores or not, but sometimes the kiddos can develop allergy to it. So then they go maybe to a soy, or there's probably 10 different varieties. And if they have to, if they're still not digesting, having diarrhea, things like that, they can even move them to, like, they call it liquid gold. So it's like this specialized formula you get from the pharmacy. But again, looking at spitting up, is it spitting up because of the milk allergy, or are they spitting up because they're overfeeding them? Term infants have iron stores that last 4 to 6 months. So when we start to introduce the iron cereals, right, like your little cereals that you start to feed them between 4 to 6 months of age, the iron in that cereal is going to give them what they need. So they don't typically need to have issues with that. However, if they are breastfeeding and they don't introduce the iron fortified cereals, they're gonna need the iron supplementation of 1 milligram per kilogram per day. Formula already has iron in it, so you don't need to give them any kind of iron supplementation if they're taking formula. We look at their glucose, so again, sometimes after birth it can be a little bit low, and then should rise and stay within normal range. Less than 40 when they are born, you'll see them jittery, lethargic, maybe feeding problems. They need some sort of intervention at that point there. Jaundice can also develop during this time, and we also want to administer their vitamin K at birth, again, to decrease the risk of bleeding. A lot of times parents confuse that, they think it's an immunization, so again, just education, letting them know that it helps to reduce the risk of bleeding. They also can be at risk for infection, so looking at things like temperature instability, irritability, poor feeding, tachypnea, things like that could tell us that they're at risk for infection, or that they have an infection. Looking at their skin, again, the vernix, kind of that white, I would say it's like real thick lotion, right, that's on their skin. It helped protect them when they were in utero. It'll slowly start to wear off. Again, we'll wash them a little bit during a bath, but if they get some that's like really stuck in their elbows or their armpits or things like that, we're not gonna scrub. Their skin is very sensitive, like paper thin. We don't wanna tear the skin. They can, like we talked about the acrocyanosis, again, I have another picture of it up there with that baby. And then some babies have erythema toxicum. So this is a rash, and they get it kind of on their face or on their chest, on their arms or their legs, but it won't be on their hands, the palms of their hands or the soles of their feet. A lot of times people call it baby acne, right? So it'll resolve itself. There's no need to do anything for it. Sometimes babies have Mongolian spots. So the picture down below here on their bottom is a picture of a Mongolian spot. A long time ago, they used to think they were bruises, right? So they would work the parents up for signs of abuse, but then they came to find out that they were birthmarks. So you'll see them at the base of the spine, on their bottom, back of their shoulders, common with those of Asian, Indian, or African descent. And then sometimes babies will have stork bites, and I think in a couple pictures I can show you a picture of Jack's stork bite. But they have these little, they're flat, kind of pink, they're easily blanched. You can get them in the nape of the neck or the upper eyelids. And then sometimes even babies have port wine stains. They call it port wine because it looks like somebody dumped a glass of red wine on their face, right? But that's not blanchable, typically on the face and neck. Sometimes female babies can undergo pseudomenstruation. Again, it's just working out mom's hormones. It's a normal thing. You would just document it. If they remain uncircumcised, the male patients, we do not retract until they're 3 or 4 years of age. But in the male patients, we'll look for things like hypospadias, undescended testes, or inguinal hernias. Skeletal, so when we look, the infant cephalohematoma, again, about only 1 to 2% of live births, and it usually happens because of those assistive tools, like we talked about, the vacuum assisted or the forceps, things like that. So again, it's just a collection of blood between the skull bone and the periosteum, so it goes away and resolves itself, usually within a couple days. And then they can have caput. Caput is swelling or edema of the scalp. It looks like a lump or a bump. You can kind of see it in the picture there. Again, harmless. It's just because of the pressure put on the head during the delivery. We want to look at baby's spine, looking for any kind of sacral dimples. Again, could be a sign of spina bifida for us. We're inspecting baby's hands and feet, polydactyly extra digits, or oligdactyly missing digits, or even syndactyly fused digits, right? We want to look and see the baby in the lower right-hand corner has club foot. So again, it turns in kind of that plantar flexion. And then also looking for things like fractured clavicle from either an macrosomic baby or maybe if they had shoulder dystocia. We want to inspect for hip dysplasia, and I'll play you so like a 1-minute video real real quick, because I like it because it shows what's happening inside the body. You can't see it. You perform Barlow and Ortolani, but you don't know what's actually happening, right? You know you're supposed to look for a hip click, right? But when we look at it, other things like looking at their gluteal folds if they're uneven, right? Or if you bend their knees and look and they're uneven, those could be signs too. A lot of times we see this in female patients, breech babies, or those that had a birth history of it. So just gonna play real quick the video.
How to test for newborn hip dysplasia by Dr. Nina Gold. We will now assess the infant's hips to test for hip dysplasia. Hip dysplasia is a congenital deformation or misalignment of the hip joint and is more common in infants who have a family history of hip dysplasia, or female, or who had breech presentation in utero. Assess the hips one at a time using 2 maneuvers. In the Barlow maneuver, first adduct the hip by bringing the thigh toward the midline. Then apply a gentle posterior pressure to the knee. In the Ortolani maneuver, flex the infant's knees to a 90-degree position, then abduct the legs by folding the thigh outwards.
So again, you can see that's where the hip is going to click or dislocate if it's not properly in place. You'll also assess the newborn's reflexes. Again, moral reflex, so extending the arms and letting go, and they kind of do like that. Sometimes you'll hear it called the startle reflex too. That'll be present till they're about 4 or 6 months of age. Grasp, so again, anytime you put anything in your finger, always keep your hand right. Rooting, again, you stroke their cheek, they're going to turn towards where you stroke their cheek. One of my other favorites, tonic neck. So they call it the fencer pose because it looks like they're going to fence. So again, looking at those. You can test Babinski. Again, Babinski is positive until age 1. And so we will test that as well. Babies sleep on average 17 hours a day, although it would be nice if they slept it all in one chunk, right? So that we could actually, as moms, get sleep at night. But they'll sleep a couple hours, sleep a couple hours, they just basically wake up to food and then go back to sleep. But it's best to feed them during that quiet alert or active alert phase. Crying is not as good to feed them during that time because it's hard to get them to settle down. Their eye muscles are immature. Accommodation will be present, but and their pupils will react to light. They have a blink reflex, but they can't see objects more than 50 centimeters away. They cannot detect color until 2 months of age, but as of 5 days old, they can start to detect black and white patterns and have sensitivity to light. Once the fluid drains from their ears, their hearing is that of an adult. So 90 decibels will cause the moral reflex to occur. They can respond to low frequency sounds like heartbeats, lullabies. Again, they get that routine hearing screen before they get discharged from the hospital. They can detect smells by the 5th day of life. They can recognize mom's scent and the smell of mom's breast milk. And again, they like sweet, and that can elicit the sucking reflex. And then you can get, again, reflex by touch. So we talk about the different types of temperaments. You know, sometimes people say like, oh, they were such an easy baby, like my Jack. He was the easiest baby, like, and I probably would have had 10 if I would have had all like him, but then I had Gianna second, and if I always said if I had Gianna first, I would never have had another child. She was very, very colicky, very bad. But the biggest thing is to talk about shake and baby with the parents. So before they go home, they usually have to watch a video. In the NICU, we used to have them, they'd watch a video and they actually would fill out, there was like a certificate. They would say, if I feel like shaking the baby, I'm going to do X, Y, Z, and they'd have to fill in the blank. And you know, if I feel this upset and it still doesn't resolve, I'm going to call this person and here's their phone number. So they actually wrote out a plan before they went home and then they signed it. I took care of a patient, there was he was about 17. He was a total care patient that was in with some respiratory illness at the time, and I was talking with mom, and she said, he wasn't born this way, and, so sometimes you're like, okay, they probably wanna tell me their story, right? So she said, I like to tell my story, I like to tell nurses. So she was a single mom, she was working 2 jobs. She, usually sent she had twins, a boy and a girl, and she usually sent them to her mom's at night, so she could go work. And she started dating a guy, and so she had the boyfriend come over, and he's like, you know what, just leave the kids with me tonight, I'm gonna go take care of them, they can stay here, don't worry about taking them to your mom's. Well, she came home, and the boy, when she came in, the boy was just like kind of laying lethargically in the crib, and she's like, what happened? He's like, I don't know, I didn't see anything, weird happen. Took him in, and found that he had been a victim of shaken baby syndrome. So all growing up, she had this beautiful, wonderful daughter who was a constant reminder of what her son could have been like had she not made that one decision, 17 years ago, to allow the babies to stay home with the boyfriend. So she said she always likes to share her story, so that always stuck with me, because that's why when I say like, watch the shaken baby syndrome, who's gonna shake their baby? Well, people shake their babies, right? Seeing it from a pediatric standpoint, how many babies would be brought in to the ER that have been shaken, it is a real thing. So when we think sometimes it's silly to play the video, or they used to have a big ad campaign, never, never, never shake a baby and all this stuff like that, but it's for real because it does happen. Alright, so I have another NCLEX question for you. 9-hour-old infant, passes an informed black tar-like stool. What conclusion should the nurse draw from this finding? That it's a transition stool that's expected later, a transitional stool expected at this time, it's meconium expected at this time, or it's meconium that should be expected at time. C. Yeah, so C, it's meconium, it's expected at this time. Alright, last one on the paper here. So the stuff on the newborn that we talked about, just that chapter there, and then this one here that we'll go through, is not on exam 3. It is on the final exam. However, we don't have enough time next week to lecture on the newborn, since we have to take a test. So I start the lecture this week, and then we have 2 more pieces we talk about next week. But all of that will be on the final exam on exam 3. All right. As when babies are born at 1 and 5 minutes of life, we perform the APGAR. We've talked about that several times. You always want to wear gloves when handling the baby. Again, they're exposed to blood and amniotic fluid. Again, you don't want to touch that baby. I know we had one yesterday that even the mom was Hep C positive, and we didn't get that in our report at all. So then, halfway through the night shift, they said, the patient or the patient's nurse, by the way, this patient is Hep C positive. That was a nice tell, of course. But always do good. Always wear your gloves, right? We're going to look at the general appearance of the baby, their color, their reflexes. Looking at their sutures and their hair distribution, their eye placement, their ear placement, looking for torticollis or that wry neck that sometimes they can have, taking their vitals, making sure they're within appropriate ranges. So gestational age of the baby, we want babies that are appropriate for their gestational age. So anywhere between the 10 to 90th percentile if you were to plot them on a growth chart, right? When we have large for gestational age babies, that would be over 90%, and then small would be under 10%. At birth, babies, we're going to again make sure they have a clear airway. If we have to suction them, we'll suction them. We'll make sure that they're either under the radiant warmer or skin to skin with mom to try to help maintain that body temperature. They're going to get erythromycin in their eyes and a vitamin K shot. So a lot of times you'll hear it called eyes and thighs. And then at 24-hour screening, you'll get that hepatitis B vaccination. American Academy of Pediatrics has recommended the supplementation of vitamin K, again for risk of bleeding during that time. Now sometimes we can have babies, they call them the great imposters, and these are late preterm, so they're still preterm, but these are babies born between 34 to 36 weeks. So a lot of times they can be normal sized-ish for a baby, but they're at risk for things like respiratory distress, temperature instability, hypoglycemia, feeding difficulty, hyperbility, So again, we gotta watch these babies a little bit closer. Some of you saw the 24-hour screening. Again, one of the things they test for is jaundice, so we use the TCV or transcutaneous bili. We depress it to the forehead and get a reading electronically on it. It looks almost like a little temporal thermometer. And you're gonna get that reading of the bilirubin. If it's high, we're gonna send off a blood level, see what that comes back at. And then you need to have phototherapy. In extreme cases, transfusions, but very, very rarely. But again, we wanna make sure that we're identifying that so that we don't allow it to progress to kernicterus or brain damage to the baby. They're also at 24 hours of life going to have the state metabolic screen. It varies from state to state what they test. So we're gonna warm the heel up, puncturing that outer aspect of the heel to avoid penetration of the bone or damage to the nerves. You can see on the screen, these are some of the things that are tested across all the states, right? So things like sickle cell or thyroid, every single state is going to test for those, right? But they always say, it's funny when they show the description of it online, it says only 5 drops of your baby's blood are needed to identify these at-risk solutions, these at-risk conditions. But for my group, you know, there's more than just 5 little drops that go in those circles. These pieces of paper, the tests themselves are like $100 just to get the papers. They have to fill in the circles completely. Front and back has to be filled in completely. They can't color outside the lines, so they can't be all over the page. On there, they have to fill it directly in that circle. So it does cause a lot of trouble sometimes. And then you gotta let them dry completely so the blood doesn't smear. Like there's a lot that goes on with these tests. But again, it approximately identifies 3,000 babies with abnormal results. Just because it's an abnormal result doesn't mean they have it, right? So it can come back and say, oh, we think they have cystic fibrosis, right? But we know that this test isn't indicative. It's the, the sweat chloride test, right, that we're going to use for that as definitive, right? So again, looking at this, we want to make sure we further test. Also at 24-hour screening, we're going to do the CCHD, so the congenital heart defect. We're screening for about 1 in 4 babies has a heart defect, so again, can be identified this way. We do it at 24 hours, always in the right foot or right hand, and it can be right or left foot. We're doing a pre-ductal and a post-ductal evaluation of the baby's pulse ox. So it has to be above 95% in both extremities, and both extremities have to be within 3% of each other. So if hand is 99 and foot is 98, baby passes. If hand is 99 and foot is 95, baby fails, because again, it has to be done. They can rescreen up to 3 times, and if it still doesn't pass, then they're going to be sent off to cardiology for an echocardiogram. Circumcision, so American Academy of Pediatrics recommends circumcision to reduce the risk of UTIs, the risk of penile cancer, and the decreased risk of HIV acquisition in males. So we usually we usually wait until at least 24 hours of life, just due to the clotting factors. It can be performed using a Gomco clamp, Mogen clamp, Plastibell. So again, this is an example of a Gomco here, where I would say it looks like a little bit like a medieval torture device, right? But we get that medical device that holds it, and then they cut away the foreskin. With the Plastibell, they put the bell over the glands and then tie it off. With the Gomco, we use Vaseline afterward. With the Plastibell, we just leave it. They do get lidocaine given to them for pain, but in my group, I tell them, they say you're supposed to wait 5 minutes for the lidocaine to kick in, and for those that have seen the circumcisions, they don't wait 5 minutes for it to kick in. We used to give them Tylenol after. The nursery there said that they don't give it any longer, but I guess I looked it up and there's really no accepted practice that says not to give it, but maybe they thought it wasn't helping at all. But they'll give them a little pacifier dip or a gloved finger dip of the Sweeties while the procedure is being performed, and that usually tends to help them there. But you're going to look for excessive bleeding afterward and monitor the bleeding. You can use NPAS or NIPS or CRIES, again, looking for pain assessment in those newborns. And here's a picture of my Jack. It's hard to see up here, but he did have like a little stroke fight right here. But that was him wide awake at 2 o'clock in the morning when he was born. But again, we want to try to encourage parents to interact with their child, cuddle them. Again, if they're doing a good job with something, give them, positive reinforcement. Encouraging mementos, so we do like the footprints. I know we tried handprints yesterday, it's very hard. But, we want to teach them about thermal regulation, so again, making sure that they're dressed for the environment. So now as it starts to get warm out in the summertime, we don't need them in, a onesie and a blanket sleeper and, all this heavy stuff, right? So a simple, sleep sack or a lightweight sleeper will be fine. We want to teach them how to use the bulb suction if they needed to do it at home. We want to talk to them about back to sleep. Again, you did your back to sleep training. So again, alone on their back in a crib, the ABCs, a firm mattress, no toys, no bumper pads, no excess blankets or pillows. Don't prop bottles when they're feeding them, because again, the babies can choke or aspirate on the feed. Trying to teach them about feeding and elimination, and trying to avoid any kind of exposure to secondhand smoke. This is a picture of Jack here too. This car seat had an insert sewn in, okay, so it was sewn into his base. But you want to discourage parents that buy extra inserts to put in there, because they can shift and actually cause the baby to become injured in a car crash. So going through car seats, for those of you that have Lexi is a car seat installation specialist, so she can help them, but there are specially trained people to help them with that. We always want to make sure that in the NICU, we used to have to walk them out, make sure they put them in the car seat. We would check the straps, we'd see that they put them rear facing in the back seat, with their harness secured. Now, I feel like at the hospital, they're just like, do you have a car seat? Okay, see you later. Like, nobody checks it. But one time we had students at Barberton that were like, oh, sorry, we took so long discharging, we had to help mom. I have the same car seat at home and she didn't know how to do this one, so I adjusted the straps and helped her. I'm like, no, you can't do that because of liability, right? Now, some babies will have to have what's called a car seat challenge. So again, when we think about the car seat challenge, if they're born too early, like a premature baby or a low weight birth weight baby, sometimes they can't tolerate the ride home in a normal car seat. So when it's time for them to go home, we'll put them in the car seat with a pulse ox and a cardiorespiratory monitor on them, and make sure that they can maintain their heart rate without dropping, maintain their sats without dropping, for however long it takes them to drive home, or 2 hours, whichever is longer. So if they live 3 hours away, then they have to sit in the car seat for 3 hours. If they only live 30 minutes away, then they gotta sit in the car seat for 2 hours. But they do that to try to prevent it. They'll get a couple challenges to do it like twice. If they still fail, then they have to go home and they need these special beds for the cars. We're gonna teach mom about bathing, so again, a sponge bath until that cord falls off. And then again, no immersion baths until that cord falls off. We wanna look at signs and symptoms of illness and cover that. Talking to them about cord care, so like folding down the diaper. We no longer, in the olden days, used to clean it with alcohol to try to get it to dry out faster. We don't recommend that any longer. And talking to them about what to do with the baby's colic. All right, one more question here. The nurse is preparing to administer an IM injection to the baby. And so we want to explain what is this medication. I'm not going to tell you what it is, because maybe you remember from a drug card. But the medication treats hemorrhagic disease. The medication supplies vitamin K. The medication is a multivitamin, or the medication is a water-soluble vitamin deficient in parents. What do you think? B is a sleep. All right, so now we're going to do a fun activity. No nurses speak today.